Thank you for the kind introduction, Dr. Said. Okay. Now, first of all, I want to thank the organizer, especially Dr. Ayman, for inviting me to talk into this first meeting for rare disease. So it's a true honor. So I'm going to try to make it work. Yes. So this is a summary of my talk. So first of all, what is Huntington disease? Because a lot of attendees are specialists in many various rare disorders, but of course there are so many that I have to do a quick reminder. Where are we in research, state of the art, disease modifier treatments, repair therapies? What are stem cells? Then stem cells in HD, first of all with preclinical studies and then ongoing clinical trials, and how to move forward now. And then I will conclude. So Huntington disease, as you know, is a rare progressive neurodegenerative disorder. So it gradually kills neurons, mostly the striatum ones in the brain, and this slowly deteriorates a person's physical and mental abilities. And this disease is a genetic one, according to an autosomal dominant pattern, mutation of the IT15 gene on the chromosome 4. And there is no cure, unfortunately, and it's fatal in 15 to 25 years. Most cases of Huntington disease are diagnosed between the age of 30 and 50, and there is also an early onset form of the disease called juvenile Huntington disease. It affects people under the age of 20. So there are many symptoms, so I'm going to do it quick, but mostly you have a mix of combination of a cognitive impairment, of movement disorder, and more especially chorea and psychiatric troubles. And here in the videos, you can observe a patient with a typical choreic movements. So now, one point which is very important for this talk, which is about repair therapies, is there is a kind of specific selectivity of neuron degeneration. I mean, when you have the, yes, when you start the disease, okay, you produce a mutated Huntington, even if you don't know exactly what is the usefulness of the wild Huntingtons, you know that when it's mutated, at the end of all these cascades, you have a degeneration, a selective degeneration of medium spiny neurons inside the striatum, which is a part of the brain, as you know, with here the caudate nucleus and here the putamen. And both structures undergo a generation. And finally, you have also an axonal retrograde degeneration that produces a global brain atrophy, partly. So now, here in blue, you have the, you have the clinical symptoms. In red, you have the neuronal loss. Here, you got the pre-manifest stage and then the manifest stage. And then, currently, we have only symptomatic treatments. It means we cannot influence the progression of the disease or even reverse the neuron loss, of course. So we have several potential therapies, and especially the DMT, the disease-modifying therapies, and the goal of this is to slow down or even to hasten the progression of the disease, and of course to improve the symptoms. And you have also another type of therapy, which is the cell therapy, and the cell therapy is the only one that is able to reverse the neuron loss. So, of course, the Holy Grail currently is to combine cell therapy, so you have to repair the brain and you have to stop the degeneration process. So this is the Holy Grail. So if you focus on the neurodegeneration and disease-modifying treatment, so you have many trials with many different drugs that unfortunately have failed to slow down the disease. More recently, you have also new strategies to try to lower the Huntington productions, targeting either the gene, either the production of the protein with the oligonucleotide antisense, ASO, or to target techniques like RNA interference. And I will have a quick talk about this. So, and you have, of course, strategies to regenerate, to repair the brain with either stem cells or primary fetal striatal tissue that you can put inside the atrophic striatum, inside the putamen and inside the caudate nucleus. So what is the rationale for repair therapies in HD? The rationale is to restore striatal cell loss through implantation of dopamine-releasing cells, to make synaptic connections, to restore neural circuitry, to reverse extrastriatal retrograde degeneration, to achieve clinical improvement. So now let's start with what has been tried first, fetal striatal tissue transplantation. And I have unfortunately to admit that I'm not going to talk about ethical, of course, this is another issue, but definitely this is very disappointing. And there are two nice papers by Anne Rosser team and by Catherine Bashu-Levy that aim to focus on this point. So here you have a summary of all the clinical trials that have been attempted with fetal cells, and you can see this MIG HD trial I've participated in as a primary investigator. The biggest trial with 45 patients, and unfortunately, no clinical benefit. This one has been published in 2020 in Movement Disorders. No clinical benefit. So it was really a shock for us because we have been conducting this trial for 1 decade, and finally, after 1 decade of work, no clinical benefit. So we have several reasons to explain that. First of all, as you can observe, the study timeline, patients were transplanted between 2021 and 2013. Can you imagine such a long clinical trial? So we faced practical organizing difficulties for undertaking a transplant study with fetal cells. It's so difficult within one single center, so you can believe that as it was a multiple center trial, it was even much more difficult. But for example, we achieved, it's not exactly 90 grafts, it's 86, but okay, 86 grafts, but with 163 occasions on which surgery was cancelled due to inadequate or insufficient donor tissue. So all the team was ready. The logistic is so complicated, and we had to cancel the whole procedure because, of course, the key point is, are we going to have a tissue to graft the D-Day? This is one issue. We had also to face poorly established regulatory framework, and on this curve from 2002 to 2013, the red portion of the curve just indicate we had to face some difficulties with the regulatory and the institutional authorities that, of course, was also the reason for a much delayed study. So, why did it fail besides these practical organizing issues? It failed because, as you know, clinical improvement is related to enough functional donor cells, I mean medium spiny neurons, to re-innervate the host tissue, to make synaptic connection, to restore neural circuitry. And negative outcomes were clearly related to too small or unhealthy graft. For example, it's not an example actually, you have to bear in mind that in 82% of the graft patient, we didn't observe any FDG binding, any metabolic activity of the graft using PET scan. So how can we explain that? Poor viability of transplant cells, lack of integration of the graft in the host tissue, donor tissue outside the optimal gestational window, poor vascularization of the graft, non-permissive host environment, and what we did not expect at all when we started this trial, immune rejection. And here we published the first case of immune rejection of a brain graft, while we definitely could not believe that it could happen. So after this failure, because we have to call it a failure, now it's a failure, but it has shown the way to stem cell therapies, definitely. And as you know, now we can use stem cells. It's still very theoretical, but we can propose stem cells now in various neurodegenerative diseases like ALS, like Huntington disease, but also Parkinson's disease and Alzheimer's disease. But the way is very, very long to success. What is regenerative medicine? So let me go back to a few definitions. So the NIH definition is a process of creating living functional tissues to repair or replace tissue or organ function lost due to age, disease damage, or congenital defects. And this field holds the promise of regenerating damaged tissues and organs in the body by stimulating previously irreparable organs to heal themselves. And that also creates Mason's definition to replace or to regenerate human cells, tissue, or organs to restore or establish normal function. This is the basic definition. So what are stem cells actually? Stem cells are unspecialized cells with the capacity for self-renewal, asymmetric division, and transformation in other mature cells type. This is called potency. And next step is, after stem cells, is a progenitor cells. It's a step between stem cells and specialized cells you want to graft. These progenitor cells are capable of differentiation, but are not capable of self-renewal. So this is just a quick slide. This is not my topic. This is the specialty of Dr. Yandi, who prepares a talk with me. He's a clinical immunologist at the Abu Dhabi Stem Cell Center. And just to show you that there are many ways to reprogram the cells to achieve some progenitor cells that are going to induce some neurons or astrocytes or oligodendrocytes. Here you can see that we had a few preclinical studies in HD rodent model with stem cells, either with human embryonic stem cells or with induced pluripotent stem cells, the iPSC, or with adipose-derived stem cells, or with bone marrow-derived mesenchymal stem cells, or with genetically modified mesenchymal stem cells. So all these preclinical approaches in animal models were quite very encouraging. I would not say fully successful, but very encouraging in this to promote this approach of regeneration. Now, I want just to do a quick focus on this one, because it's a very, very interesting and recent paper that started to touch what I call the Holy Grail. I mean, a combination of brain repairing with stem cells, sorry again, but to be combined with gene therapies to lower mutated Huntington production. So you repair the brain and you try at the same time to stop or to slow down the degeneration process. So this is the first attempt to combine those two approaches, which are completely complementary. So preliminary result, I'm not going to get into the details, but these preliminary results were really very, very encouraging, but again, it has to be confirmed in preclinical, other preclinical trials, but also later on in clinical trials. So now let's move to the clinical trial in HD. So far, nothing has been published. So we have a handful of ongoing clinical trials, but nothing published so far. And I just want to focus on this, which is a website of the Stem Cell for Huntington Disease group, which is a specific group that combines some experts in Huntington disease, whose aim is to try to develop the best way to make stem cell therapies a success. So if you go to the clinicaltrials.gov website, you can see that you have 4 ongoing clinical trials. One with intrathecal transplantation of autologous means, one with IV administration of mesenchymal stem cells, another one here. And you have also another clinical trials which aim is to test iPS cells. Ongoing, it means no results so far. Now, how to move forward, actually. This is really a big issue. So what are the strategies for developing new HG therapies? It means what are the next steps for future trials? First of all, we definitely have to increase our knowledge about graft component. Are medium spiny neuron enough? So we have to use information to enhance stem cells derived products. We have, of course, to test it in animal models, either lesion models or genetic ones. We have to try to improve surgical devices and surgical procedures. Yes, I have to admit that surgery is not the only way to administer some stem cells. You can do it by IV or even intranasal administration. But so far, since we have a disease with a very localized, very privileged neuron degeneration inside the striatum, this is the reason why so far all the attempt has used surgery to administer the cell therapies. So, and you have also to understand more about alloimmunization. This is very, very important because, again, we did not expect that it could be an issue, especially since we took the caution to administer some immunosuppressive drugs during this MIG-HD trial. But despite these cautions, we observe this kind of brain graft rejections, with also it was correlated with HLA antibodies. So this is definitely an issue. We thought brain was protected against this kind of immune issues, but definitely not. So now, if we want to move after that to clinical studies, we have to think about newly designed protocols, new cells products, a better patient selection, outcomes improvement and digital measures, surgery, this is an important point, the control of alloimmunization, and you have to standardize the protocol, and you have perhaps to find some innovative statistical methods. So, newly designed protocols, better patient selection, outcomes improvement, and digital measures. So definitely we need to try to administer this treatment much earlier. We have to try to intervene in pre-manifest stage or pre-symptomatic or prodromal. And for that, we have to identify family members at risk. So definitely we have to do it earlier. And after that, we have to do it as a pre-symptomatic stage. We have to use neuroimaging and biomarkers to detect pre-HD and early HD individuals. We need a refinement and automation of outcome measures to try to reduce bias. We have to use higher sensitivity measures of cognitive behavior and motor functions, not only with the classic UHDRS scale. And we have to use neuroimaging like volumetric MRI that has been promoted in the tracker study led by Sarah Tabrizi, and PET scan with new ligands, for example, phosphodiesterase, and new biomarkers to monitor the disease progression in symptomatic patients. So the sources of stem cells, we can take some fibroblast of a donor, of the patient himself. Then we can reprogram these cells to give some iPS, induced pluripotent stem cells. Then we will have some medium spiny neurons, progenitors that will differentiate in oligodendrocytes, altrocytes, or of course neurons. We can also skip this stage to directly have these progenitors from the patient or donor fibroblast. But we can also produce some adipose-derived stem cells or mesenchymal-derived stem cells which can also differentiate in neurons oligodendrocytes and altrocytes, but on top of that, it can also produce some growth factor, which are lowered in Huntington disease, like BDNF or GDNF. Surgery procedure. Definitely, if we keep this surgery procedure, this is a very important point. This is just for one day, that's true, but this day must be perfect. To put some cells inside such a big target, which is a striatum, can seem easy to perform, but it's definitely not. Because of the striatum atrophy, because of the risk of bleeding, because we need to put it in the different functional subdivision within the striatum, because you have a motor striatum, you have a cognitive striatum, and you have a behavior striatum. So this kind of functional surgery is definitely not trivial, and it needs a specific training. And neurosurgical procedure is a D-Day, and it should be optimal. So standardization and optimization of procedures to ensure the cells are inside the target with the CT monitoring during the procedure, and with also the use of improved cell delivery devices, and it should be also improved by robot-guided surgery. We have to adapt the number of graft tracks according to the striatum atrophy, and we have, of course, to control the risk of bleeding. Regarding immunization, okay, I'm going to switch this one, but of course, with stem cell-derived products, we could have maybe good surprises. Even we have to be very careful, and we have to continue to check the matching between the donor and the host regarding the HLA system. It should be a necessary caution. So, in conclusion, so I would say, again, the holy grail in these new therapies is a combination of we have to repair the brain and we have to stop the production of mutated Huntington. So, oops, sorry. So you can observe, I've talked about the Huntington lowering therapies with the ASO, with the RNA interference, both aiming to target either the gene or the production of Huntington itself. So we have two clinical trials led by Roche that started now a few years ago. The phase 2 study was really fantastic. And when we moved to phase 3 studies, we had great hopes, and finally it failed. And here you had a press release, double setback for ASO trials in Huntington disease. So therefore, stem cell therapy is now the only approach currently focused on structural and functional restoration, and it's the most immediate promising option, if, of course, even if we are not going to give up with these lowering therapies strategies. And so that's what we're going to do in the Abu Dhabi Stem Cell Center, especially with Dr. Yandi and Dr. Yendri and Dr. Fatima. So, and I hope we are going to start shortly to develop new innovative protocols to achieve this goal. Thank you so much for your attention.